Hello, welcome back. My name is Dr. Bal, and today we are going to learn ABCD of primary hypertension. Um, Primary hypertension is the most common reason for office visits and for the use of chronic prescription medications here in the US. So, hypertension is a global burden and disease. It is more common in male than female, and people who take blood pressure medication, their blood pressure is better controlled in non-Hispanic white adults than in non-Hispanic black adults. So let's very briefly talk about the pathogenesis of hypertension. These are the learning outcomes. So pathogenesis of primary hypertension is very well studied but poorly understood. I believe it's multifactorial. It has to do with genetics and their environmental factors that may have a multiple compounding effect on the cardiovascular and renal structure as well. Now, in general, blood pressure can be determined by this equation over here. Blood pressure equal cardiac output times systemic vascular resistance, or sometimes we call it TPR, total peripheral resistance, same thing. Now, remember, blood pressure is amount of force that is exerted on the blood vessel. So when left ventricle contracts, it pushes blood away. And so what is the amount of force on the blood vessel? So that is blood pressure. Cardiac output is amount of blood we eject in 1 minute. So that's cardiac output. Now, the systemic vascular resistance has to do with the diameter of the blood vessel. Diameter. Also, another factor could be, so for example, if you increase the diameter of a blood vessel, if you make it bigger, you are going to decrease the resistance. When you increase the diameter, when you make it smaller, you would increase the resistance. So when you increase the resistance, you are increasing the blood pressure. So you can say that decrease, you can say that decrease diameter means you're increasing the SVR. And by doing that, blood pressure will go high. And the second part of the story is length. Now, we are not necessarily increasing or decreasing the length on any given day, but generally speaking, when you have a client with a larger body mass, obese client, every kilogram of a fat requires more blood vessel, right? More blood supply. So when you you need more blood. So in other words, you can say that when you increase the length, it increases SVR, so the blood pressure increases. So again, think of an obese patient, blood pressure is higher than someone who lose weight. Okay, the third part is the viscosity of the blood, how viscous the blood is. So viscosity has to do with the how thick or thin the blood is. So needless to say that if the blood is a thick, for example, in case of a dehydration or in case of polycythemia, when you have more particles present in the blood, so you're increasing the viscosity. So it's gonna, if it's a thicker, then you're increasing the resistance. By increasing the resistance, you're increasing the blood pressure. Or if the blood is a thin, if you will, for example, in case of anemia, you have a less number of RBCs, then you can say that you have low blood pressure. So anyways, this was just a very brief description of how to calculate blood pressure. Now, there are different types of blood pressure, or not, well, generally speaking, there are two types, you can say, primary and secondary, something that we used to call idiopathic. Idiopathic means we have no clue why you have a blood pressure, or there are many reasons, I should say. The secondary hypertension almost always have some kind of underlying reason or factor or cause that we should be able to treat. Once we treat that, the blood pressure improves. So this is not necessarily a chronic. So as you can see, if you have a renal disorder or some endocrine disorder, like a few chromocytoma, Cushing syndrome, pregnancy, some medications can cause blood pressure, like oral contraceptive medications and so forth. I think you got the point here. If you treat these things like obstructive sleep apnea, then the blood pressure improves. Now today the topic, we are not going to focus on secondary hypertension. Secondary hypertension is managed differently. You treat the underlying cause and you go from there. Our topic is primary or essential hypertension. That's what we are going to focus on today. Risk factors for hypertension. We can divide risk factor into two different categories. On the left hand side, you have a non-modifiable risk factors. This is something that you have no control over. For example, age, gender, family history, you have no control over that, and ethnicity. So we will see in a few minutes or so, in some ethnic groups, blood pressure is managed differently. Some ethnicity respond to blood pressure medications differently, so it does matter what is your ethnicity as far as the treatment management is concerned. Strong family history is putting you at risk, so there's a genetic component, you can say. But on the right hand side, this is where we should be spending our more time and energy teaching our patients on modifiable risk factors. For example, obesity, overweight. As I just mentioned earlier, that when you have more body fat, you are increasing the resistance, so blood pressure tends to go high. A high sodium diet, smoking tobacco can cause hypertension because of a vasoconstriction. Alcohol, sedentary lifestyle, so we know all that. So it's worth mentioning these items when we treat hypertension in a primary care setting. This is just a typical, like a poster for modifiable risk factors, you can say. So it's a diet, smoking. I think we're missing a bottle of alcohol or something like that. So it's visual reminder of some modifiable risk factors of the presentation of a typical hypertension client. All right, hypertensive client, I should say. All right, complication. Why do we care? Why are we talking about hypertension today? Well, hypertension is the most important modifiable risk factors for premature cardiovascular disease. There are certain disorders that stem from hypertension, and we just saw the modifiable risk factor for hypertension, but then hypertension is also most important modifiable risk factors for other cardiovascular disease, such as left ventricle hypertrophy, where the left ventricle is enlarged. Heart failure. Hypertension is one of the risk factors, modifiable risk factor for CHF. For both, for a reduced ejection fraction, which is systolic, and preserved ejection fraction, diastolic heart failure. Ischemic stroke, intracerebral hemorrhage in the setting of hypertension. So all of these things can be prevented up to some extent if we control someone's blood pressure. And we also know that most of the time these patients are asymptomatic. Hypertension is painless. It's not a painful disorder. So most of the time you may not even know. If you don't check it, you won't know that you have high blood pressure. So we call that silent killer. That's why primary prevention is so important. Make sure that you have a follow-up with the primary care provider, do the blood pressure checks frequently, especially if you have the risk factors or a family history. All right, staging of blood pressure guidelines. Now, I can't believe that we have been arguing over a few millimeters of mercury over the past several decades. What do I mean by that is that here in the US we have different guidelines than Europeans and then Asian guidelines, and even here here in the US we change guidelines so often. But one thing we all have agreed on is that systolic blood pressure of greater than 150 is bad, and we must treat that. Now the question is, who do we treat? Do we treat everybody? And what do we treat them with? So even though this is a very important question, but the answer depends on your patient, and this is a discussion that as a provider we should have with our patients, when to treat the blood pressure and what do we treat these blood pressures with, what kind of medication do we pick, and what is normal. I personally believe, I think I mentioned before, that normal is just a setting on a washing machine. In human body, there's no such thing called normal. So anyways, but as of today, the most current guidelines are that the normal blood pressure, if there's such thing, is between systolic blood pressure less than 120 millimeter of mercury and diastolic less than 80. So you can say 120 over 80 or less than 120 over 80 is normal. Now, if you have a patient whose systolic blood pressure is between 120 to 129 and diastolic is still less than 80, that is considered elevated blood pressure. When the blood pressure increased from 130, between 130 to 139, and diastolic is now has increased from 80 to 89, that's the range, the patient is in stage 1 hypertension, and stage 2 hypertension is any blood pressure, systolic blood pressure above or equal to 140 and diastolic 90. So that would be stage 2 hypertension. If there's any disparity in category between the systolic and diastolic pressure, the higher value should determine the stage. So for example, if you have a patient whose blood pressure is, let's say systolic blood pressure is 142 and diastolic is 82. So if the systolic is 142, then you're here, but the diastolic, I'm telling you, it's 82, so it's right here. So this patient should be staged as stage 2 hypertension, not 1. So you always go with the higher value. All right. Home or ambulatory blood pressure monitoring. Let's see, the diagnosis of hypertension requires the integration of home or ambulatory blood pressure monitoring, whereas the routine measurements made in the clinic setting should be used for screening purposes only. So you have we have the diagnostic criteria that was suggested by the American College of Cardiology and American Heart Association guidelines, meeting one or more of the criteria using the ambulatory blood pressure monitoring. So what they're trying to tell us is that keep an eye on the daytime blood pressure, daytime, which is awake, mean blood pressure of 130/80 or above, and nighttime 110 is a systolic, and diastolic 65 millimeter of mercury or above. Generally speaking, the blood pressure at nighttime is lower than the daytime blood pressure. So it's very, very important for our patient to have a log sheet, and you tell them, I'm not going to diagnose you based on one number here in the office. Here's the log sheet, and I want you to check blood pressure in the morning when you wake up and at nighttime, and then you bring that log, and then we will go from there. Now, the reason we do that is, number one, it's never a good idea to diagnose based on one number, and also we have a concept of a white coat hypertension, where blood pressure that is consistently elevated by the office reading but does not meet the diagnostic criteria for hypertension based on out of office. In other words, at home blood pressure is okay, but in the office it's high. Why would you ever treat with just one number that is higher in the office but the patient is okay at home? And this is the opposite, where you have a masked hypertension, blood pressure that is consistently elevated out of office measurement but does not meet the criteria for hypertension. So needless to say, we should keep these things in mind when we diagnose, or most importantly, when we start a treatment for these patients. All right, talking about diagnosis. Number one thing is talk to your patient. Listen, listen, listen. Pay attention. They're telling you what's wrong with them. So take a very good history. Then you do the physical exam. Try to rule out target organ damage. Take a look at their eyes and see if there's any hemorrhage going on. What does the lung sounds like? So complete head-to-toe assessment. You know how to do that. Look at their legs, extremities. Make sure you perform a very good complete neuro exam as well. So the main goal is to really determine or evaluate signs of end organ damage. Next is what kind of lab would you do? We usually do basic lab work, such as, I will do CBC, TSH, we can do UA. We need to know the renal status of the patient. So it's worth getting serum creatinine, EGFR, and so forth. And we can always order additional tests if they're indicated in any other settings. Since these are chronic disorders, it's worth checking A1C as well, the lipid panel, and so forth, echocardiogram. These are supporting exams. They are not going to give you the answer that the patient has blood pressure or not, hypertension or not. These are the supporting exams that we do to manage our patients. According to the 2017 American College of Cardiology and American Heart Association Task Force guidelines, blood pressure should be recorded in both arms at the first visit. The arm that gives the higher reading should be used for subsequent readings. A repeated measurement should be separated by 1 to 2 minutes. Patients should avoid caffeine, exercise, and smoking for at least 30 minutes before blood pressure is taken. Patients should be relaxed and sitting in a chair with their feet on the floor and back supported for more than 5 minutes. Blood pressure measurement made while the patient is sitting or lying on an examining table do not fulfill the criteria outlined. So next time when we check the blood pressure, keep an eye on these guidelines and ask yourself if we are really following the guidelines that are out there for us. The guidelines suggest ensuring the cuff size is correct such that the blood pressure bladder encircles 80% of the arm. All right, why is that important? Well, it's the proper fitting of the blood pressure cuff is important because otherwise it will not give you the proper reading. So here's the arm circumference, 22 to 26 centimeter for a small adult. For adult size, here's the measurement. And this is important, I think. Neither the patient nor the person taking the measurement should talk during the procedure. So when you're checking the blood pressure, that is not the time to ask your patient, how are you doing today? What brings you here today? We should not be having social conversation at that time. Treatment approach. Just like anything else in medicine, we always like to start with non-pharmacological interventions. So the first one is lifestyle modification. If you are a smoker, we need to have a conversation regarding that. So stop smoking, weight loss, exercise, cut down on alcohol intake. Also potassium supplement, unless it's a contraindicated, of course. Weight loss, we know that obesity and hypertension, obesity can cause hypertension, or is a risk factor, I should say. So weight loss is recommended in these patients. All right, we know the DASH diet. All right. Now, treatment, pharmacological interventions, that's where the A, B, C, D come from. We can divide the treatment protocol in four, major drug classification, if you will. The A stands for ACE or ARBS, B is your beta blockers, and C is a calcium channel, and D are your diuretics. So there are four major classes of antihypertensive drug that JNC it makes a recommendation for the use of specific or specified situation based upon the clinical trial evidence of a decreased cardiovascular risk, blood pressure lowering efficacy, and safety, etc. So we will talk about these today. So there's so many drugs to pick from, so which one do I pick? Well, it depends. It depends on many factors, but before we really get into the drugs, I want to very briefly introduce a concept of renin-angiotensin aldosterone system. Our first drug is ACE inhibitor. That was number one. So in order to understand ACE inhibitor drug, we need to know the mechanism of action. How does the drug work? Well, the story starts from the kidney over here. We have two kidneys, one on each side. The kidney will release a substance called renin. Renin will, so from the kidneys, renin enters into the blood vessels. Here's your blood vessel. At the same time, you have a liver here, and the liver is going to release another substance called angiotensinogen. So kidney released renin, liver released angiotensinogen. Both of these are in the blood vessel now. Now, angiotensinogen with the help of renin here, with the help of renin, angiotensinogen will get converted into angiotensin 1. So angiotensinogen will get converted into angiotensin 1 with the help of renin here. That's why you needed renin. Now, angiotensin 1 here, now the next stop is lungs. So in the lungs, with the help of angiotensin converting enzyme, something that we called ACE. ACE means angiotensin converting enzymes, and these enzymes are in the lungs, by the way. So in the lungs, with the help of ACE, angiotensin 1 gets converted into angiotensin 2. All right. So angiotensin 2 is the product of angiotensin 1 that got converted with the help of ACE. Now, angiotensin 2 is a very, very powerful constrictor. It's arterial, both arterial and venous, venoconstrictor. So arterial and venoconstrictor. It's going to constrict. So recall from your physiology classes that when you have a powerful vasoconstrictor, it's going to constrict the blood vessel. So when you are constricting blood vessel, you are increasing blood pressure. You're increasing cardiac output, you can say. Same thing. So here you are, vasoconstriction, increasing blood pressure. This is normal physiology, by the way. This is not pathophysiology. This is normal physiology. Now, at the same time, what is happening is angiotensin 2 is also present in zona glomerulus, which is in the kidney, of course. Now, this will release a substance called aldosterone. Now, when aldosterone is released, it will increase sodium retention. Sodium retention is sodium is retained. It will increase sodium retention, I should say. Same thing. Now, why is that important? When you increase sodium retention, you are increasing blood pressure, you're increasing cardiac output, because remember, water follows salt. So what happened here is somehow the goal is to increase blood pressure. So what you're trying to do is you're trying to increase blood pressure by either converting angiotensin 1 into angiotensin 2, or over here the angiotensin 2 is releasing aldosterone that will further increase blood pressure. At the same time, what is happening is angiotensin 2 is also present in hypothalamus. So here's your brain. So hypothalamus area. What will happen is angiotensin 2 will act on hypothalamus, which will increase thirst. So you want to drink more water. So by doing that, if you increase thirst, you're increasing more water, you're drinking more water, so you are actually increasing more like a volume, you can say, or in other words, you're increasing more cardiac output. By doing that, you're increasing blood pressure. Same thing. So the end result is to increase blood pressure. All right. Now, the problem is today you have a client sitting in your office with high blood pressure, and we need to bring his blood pressure down. So we prescribe medication called ACE inhibitor. ACE inhibitor means that drug is going to inhibit this enzyme here, angiotensin converting enzymes. ACE inhibitors will stop that enzyme or inhibit that enzyme. What will happen if this enzyme is inhibited? Well, that means angiotensin 1 will not get converted into angiotensin 2. So angiotensin 1 will not be able to get converted into angiotensin 2, and therefore you will reverse all that. You will not have a strong vasoconstriction or arterioconstrictions. None of this will happen. So therefore you won't be able to have increased blood pressure. The blood pressure will be decreased. All right, so that's the goal here. So that is the mechanism of action of our first drug. So these drugs are called angiotensin converting enzyme inhibitors, ACE inhibitors we call them. They end with the term pril, lisinopril, ramipril, and so forth. All right. A couple of things about these drugs. Number one, they are prescribed for blood pressure. We know that. But another interesting thing is that they increase survival in post-MI or heart failure with a reduced ejection fraction, that's HFrEF, CKD patient, and diabetic patient. Okay. They work very well in young and white patients. So talking about ethnicity, these clients respond very well to ACE inhibitors. Now there is a very annoying side effect called dry cough. About 30% of the patients will experience dry cough while they are taking ACE. What happened is that ACE inhibitor, these drugs, when they were blocking the ACE enzyme here in the lungs, there's another enzyme called bradykinase. Okay, so ACE inhibitor will increase the level of bradykinin by blocking the enzyme called bradykinase. You know, it's an enzyme because it ends with ACE. So when you're blocking the enzyme called bradykinase, the level of bradykinin increases. This is another it's a side effect of this drug. So when the levels of bradykinin in the lungs increase, they will irritate the nerve endings in the lungs, and that produce a cough and irritation. Okay, so you can say that the ACE inhibitors, they block an enzyme called bradykinase in the lungs, and that will increase the level of bradykinin, and that will increase irritation, or it will cause irritation in the nerve endings, and that produces a cough. Now it's not a cough where you have a respiratory infection or bronchitis or COVID or anything like that. It's annoying, and it happens in 30% of the cases. The best treatment, honestly, would be to stop ACE inhibitors and give them ARBS, and we'll talk about that in a second. All right. Let's see. Few things that you have to keep an eye on is when you are taking ACE inhibitors, you are at increased risk of hyperkalemia, especially in patients who already have chronic kidney disease, or if you have a patient who's on some kind of a potassium supplement. You will see that in a few minutes when you have a patient on diuretics and they're taking potassium supplements. You have to be very, very careful, because hyperkalemia, which means a high level of potassium, is very bad for you. Okay, so keep that in mind. It may cause acute renal failure in patients with a severe bilateral renal artery stenosis. Do not use in a patient who have a history of angioedema, and avoid in pregnancy. So that is your ACE inhibitor. So anytime you see any of these drugs like a pills, so think of all that information that we just discussed. So let's say you have a client who was on ACE inhibitor and he's reporting dry cough. And the second best option for that patient would be ARBS. ARBS are angiotensin receptor blockers. Now these medications they will end with like a sartan, has a low sartan, valsartan, and so forth. Do not use in a combination with ACE inhibitor. So if the patient is taking ACE, you don't want that patient to be on ARB. It's one or the other. It will also increase risk for hyperkalemia. Same thing, same principle apply. These drugs are very, very similar to ACE. The only difference would be that they are not going to act on the bradykinase enzyme. It doesn't have no impact on that. They simply block the angiotensin receptors. So angiotensin is not going to work on these receptors because they are blocked by these drugs. So it has no impact on bradykinase enzyme. So therefore, the levels of bradykinin does not increase. So there's no irritation, there's no cough. And that was the purpose. That was the reason you wanted this patient to be on ARBS, right? Because the patient was complaining of dry cough. Now, the second type of class is beta blockers. Beta blockers, remember we have beta blockers, we have a beta receptors, I should say, beta 1 receptors. So these medications, and recall that the function of beta receptors in the heart is to contract, so increase contractility. So you can say heart rate or contraction. So we are going to block these receptors. So when you do that, you're going to decrease the contractility, right? So decrease heart rate, decrease blood pressure. These medications, they end with LOL. Here carvedilol, propranolol, OLOL, so metoprolol. Metoprolol are called selective medication. Propranolol is a non-selective, and so forth. All right, these medication, they are they work very well in young and white patient. They also increase survival rate in heart failure, post-MI, and AFib clients. Now this is new. You didn't see that with ACE and ARBS. They had no role in AFib. Remember, beta blockers, they control heart rate. So that's one difference between the ACE, ARBS, and beta blockers. Now this is interesting. Beta blockers are not recommended as a first-line agent unless the patient has AFib. So these are the compelling reasons. Why would you pick one drug over other? ACE and ARBS have no impact on the heart rate. They will decrease blood pressure beautifully, but not the heart rate. So if you have somebody with AFib, then this might be a good drug. But if that's not the case, then beta blockers are not first line, because it provides inferior protection against a stroke risk, particularly in patients over the age of 60. Most of our clients who are on hypertension medications are elderly clients. So if they don't have AFib or HF and heart failure, these medications do not provide a better protection against stroke. Carvedilol preferred in patient with HFrEF, that's heart failure with reduced ejection fraction. And by reduced, I mean like a 45% or so. It's always a range. Metoprolol succinate is preferred instead of a metoprolol titrate in patients with HFrEF. Now, metoprolol comes in two different flavors, if you will, succinate and titrate, and that means short-acting and long-acting. So succinate is given once a day, and titrate is a twice-a-day drug. All right, let's see what else I want to tell you. There is an issue with the metoprolol as far as depression and COPD and asthma is concerned, and sexual dysfunction. And some people just don't tolerate a beta blocker that well. People feel tired all the time when they take a beta blocker. Talking about COPD and asthma in the setting of hypertension, this is not necessarily like an absolute contraindication. You have to be very, very careful. What happened is, you know that beta-1 receptors are in the heart, but in the lungs we also have two lungs on each side, and you have a beta-2 receptors in the lungs. Beta-1 is in the heart. The way you want to remember is you have a one heart, so you have a beta-1 in the heart, and you have two lungs, one on each side, so beta-2 receptors are in the lungs. Now the function of a beta-1 receptor in the heart is to contract, constriction, and in the lungs it's a dilation. You want you want to dilate bronchodilation, so that you can breathe better, right? So when you have a client who has asthma or COPD, they have trouble breathing to begin with, and on top of that you give them beta blockers, and especially if the beta blockers are not selective, then those drugs will have impact on the beta-2 receptors in the lungs, and you will so those bronchodilation will not occur. It will constrict actually, and you don't want a bronchoconstriction in the lungs. You want a bronchodilation, especially if the client is a symptomatic client, has asthma or COPD. So you have to be very, very careful with these drugs, generally speaking. All right, and never, I shouldn't say never, but try your best not to stop these medication all of a sudden. Remember, you're blocking someone's beta receptors in the heart for months and maybe years, and all of a sudden, if you stop taking beta blockers, these receptors are going to going to go live all of a sudden. They're going to wake up, and they're going to start firing, and you will have tachycardia, you can have AFib, because these receptors were resting for many months and years, and you stopped these medication all of a sudden. So these receptors are not dead. They were just sleeping, and now they're awake, and they're going to start working. So they will start having contraction, and it's going to be very dramatic. So we try our best to taper our patients off of these medications. All right, so the third drug class is calcium channel blockers. And calcium channel blockers can be further divided into two different flavors. The first one is dihydropyridines, and in the second slide you will see non-dihydropyridines. With the first one, they end with the pene, like amlodipine, flodipine, and nifedipine. I'm sure you have heard these names before. Now, the main difference between these two is with the dihydropyridines, they mostly work on the in the blood vessels, not in the heart, if you will. So what do I mean by that? Well, they work on the smooth muscle, on the arterial, not in the vein though, arterial. They cause a vasodilation. So vasodilation is caused by dihydropyridines. They block the voltage gated, calcium channel in the smooth muscle. So the way I remember is that they really give you very smooth blood pressure control. So they work on a smooth muscles. So since they are dilating, so here's a dilation. What are they dilating? They're dilating the blood vessel, the arteries. So dilation, di, and then here's a di here, di. So dihydropyridines di. So if you want to remember that. All right. So who are good candidates for calcium channel blockers? Well, perhaps the patient who cannot tolerate beta blockers. We have to be very, very careful when you select a calcium channel blocker, because calcium channel blockers really have no survival rate in any disease. So that's one point to remember. But they are good indication. They are indicated in angina, especially like a stable angina and so forth. In CAD patients, they're not for AFib because at least these guys, they have no effect on the cardiac conduction. We'll talk about that in a second. Also avoid calcium channel in patient with HFrEF. Amlodipine or fluoropine may be used if required. There is dose related side effect of pedal edema. Some patients may report headache and flushing, so those are some things to keep an eye on. Elderly patients and African American patients are a candidate as initial monotherapy. Remember, with ACE inhibitors and ARBS, we said young white patients, clients. So calcium channel blockers, elderly and African American. Calcium channel blockers do not cause sedation or drowsiness or any sexual dysfunction that we just saw with the beta blockers earlier. All right. Here is the second part of calcium channel blocker called non-dihydropyridines. These drugs will decrease force of contraction. So remember, they're working in the heart now. So they're working in the heart. They're decreasing the force of contraction, something that we called inotropic. So you can say they decrease inotropic. Inotropic simply means the force of contraction. So if you're using a drug that will decrease a force of contraction, we call them decrease inotropic. Also, they will decrease the speed of the conduction. So something that we called contractility. So it will decrease contractility. And pardon my handwriting, please. Trying to write with a mouse here. Okay, so non-hydropyridines. So the main difference between the dihydropyridine and the non-dihydropyridine is that the earlier one, the one that we just discussed earlier, amlodipine and difidipine, and they were dihydropyridines, they do not affect the cardiac conduction system, whereas non-dihydropyridines do. What do they do? Well, they decrease inotropic, they decrease contractility. Why is that important? Well, so that they're good for AFib, angina. Oh, here they are. Decrease inotropic and decrease. I just had that in writing. I didn't see that. So they affect the cardiac conduction system. We have to be very careful with these drugs, especially if you already have a beta blocker on board. Remember, beta blocker also decrease heart rate, so avoid routine use with the beta blockers due to increased risk of a bradycardia and heart block. As a matter of fact, non-dihydropyridines are not indicated in the setting of heart block. Okay, they're not recommended in the treatment for hypertension with HFrEF. They are also Vimepil has a common side effect of constipation as well. Let's see, and there's a concept of drug-drug interaction with diltiazem and Vimepil with the cytochrome 3,4A, which is a major substrate and moderate inhibitor. So why is that important? We talked about that earlier in previous chapter, the concept of inhibitors and inducers. And with this drug, you have to be very careful with the grapefruit. It may increase the effect of diltiazem in some patients. So it's worth mentioning, or keep an eye on that. All right, so talking about A, B, C, D, your A was ACE inhibitors. If you cannot tolerate ACE, then we had ARBS. B was for beta blockers. C was for calcium channel. And I said there are two different types of calcium channel blockers, dihydropyridines and non-dihydropyridines. And now the letter D stands for diuretics. Now, what are diuretics? I'm sure you have heard people saying, my water pill, it makes you pee. Urinate. Okay, so diuretics or thiazide-like diuretics or long-acting dihydropyridine calcium channel blocker should be used as initial monotherapy in African American patient. So these guys are used as initial therapy. The examples are hydrochlorothiazide. I'm sure you have seen this, heard this before. The indications, besides hypertension, you have a CHF, congestive heart failure. That makes sense, right? You have a lot of fluid and you want to get rid of that, so you'll give them diuretic. Also, osteoporosis. It is, as I mentioned earlier, initial monotherapy in African American patients. Chlorothalidone preferred based on prolonged half-life and proven trial reduction of CVD. Keep an eye on decrease the sodium and decrease the potassium level, and increase uric acid and increase calcium levels. So a few things make sure you keep an eye on the lab is, number one, decrease sodium, decrease potassium. So these two things decreased, whereas you have increased uric acid and increased calcium levels. So here's a side effect of increased calcium level, and therefore you see an indication as osteoporosis, which we can get a benefit from these drugs. You have to be very careful with a patient who have a history of acute gout, unless patient is on uric acid lowering therapy. So why is that important? When you have a patient with a history of gout and a patient has hypertension, and if we start these patients on these medication, it can worsen their gout episodes because of the side effect of increased uric acid, unless they are on medication for that. On a side note, there was a trial called ALLHAT trial. The patient who were randomly assigned thiazide or chlorothalidone had a significantly fewer hip or pelvic fractures as compared to ACE or calcium channel blockers. Now, it is because thiazide work on the distal tube where calcium is reabsorbed. So therefore, thiazide, you can say, enhance calcium reabsorption and lessen excretion. So this is a beneficial in the patient with the kidney stones due to the excessive calcium excretion. So that is something that we learned from that trial. So, all right, next is loop diuretic. Bumix, you have Lasix here, that's furosemide, a very, very common drug. These drugs are prescribed in patient with CHF, osteoporosis, In adults with preserved ejection fraction, HFpEF, who present with symptoms of volume overload, loop diuretics should be prescribed to control hypertension. They are preferred over thiazide in patients with a moderate to severe chronic kidney disease, which means that ejection fraction is less than 30 ml per minute. These drugs are preferred. Keep an eye on calcium, because it can decrease calcium level, which is a treatment for hypercalcemia. And when the calcium is high, you treat that. Again, monotherapy in African American patients. Bumix is very potent, very strong. 1 milligram of Bumix is equal to 40 milligram of Lasix. So be very, very careful if you're doing a dose conversion from one drug to another. Let's see. All right, the other type of diuretics are called aldosterone antagonist. You have example here, spironolactone. These drugs are indicated in like a later stage of CHF, something that we called New York Heart Association class 3 and 4. New York Heart Association has 4 classes, class 1, 2, 3, and 4, and these drugs are indicated in 3 and 4, and so ejection fraction is getting worse, and these patients are more symptomatic. This is almost always add-on therapy, and this is not a monotherapy. So these are the agents that we used in resistant hypertension, and things are not getting better. A common add-on with Lasix, another diuretic that we just talked earlier, for ascites and so forth. Keep an eye on the side effect of gynecomastia. These drugs are potassium sparing drugs, so avoid the use of potassium supplements. Remember, with the Lasix, the problem was it will decrease potassium, so you usually add potassium supplements, whereas over here you want to avoid potassium supplements because of potassium sparing property here. All right, so we are done with ABCD of hypertension. So we talked about A for ACE or ARB inhibitors, B for beta blocker, C for calcium channel blockers, and D for diuretics. Now this slide will cover some miscellaneous drugs that did not fall into those 4 categories that we have discussed so far. So these miscellaneous agents are like a vasodilators. They will dilate the blood vessels. Hydralazine is a good one that we use. I have a few patients on dialysis, and we have them on hydralazine. Minoxidil is a good one for in the setting of a resistant hypertension. Then you have alpha blockers, alpha 1 blocker and alpha 2 agonist. Now, recall that, remember earlier during beta blockers, I said you have a beta 1 and beta 2 receptors, and I said beta 1 was in the heart, and the function was, to constrict or to increase contractility in the heart, increase heart rate. And I said beta 2 are in the lungs, and the purpose was the bronchodilation. Now, same thing with alpha receptors. You have alpha 1 and alpha 2. Alpha 1 will cause vasoconstriction. Just like beta 1 did, but in the heart. These are smooth muscles. And I said beta 2 was causing bronchodilation, but here alpha 2 is going to cause vasodilation. Remember, it's not in the lungs. It's not causing bronchodilation. Alpha 2 is causing vasodilation. So we are going to here with alpha 1, we are going to block these receptors. So alpha 1 blockers, we are going to block. When you block these, that means you're not going to cause a vasoconstriction. So what would you cause? Well, you cause vasodilation. That's the opposite. So it's dilation. So in other words, you will dilate. The examples that I can think of here is Cardura, which is the first one, and doxazosin, or Prazosin, which is Minipress. Now, you're not going to see these drugs, especially nowadays, prescribed as a monotherapy for hypertension anymore. We have better drugs like ACE, ARBS, and so forth. You will see that in the setting of like a BPH, benign prostate hypertrophy, and maybe patient also have a hypertension. So this is an indication. I sometimes prescribe Prazosin in the setting of a PTSD. So there's a role there, something that we call off-label, if you will. All right, coming back to hypertension, we have a drug called clonidine, which is alpha-2 agonist. Now, agonist means this is not antagonist. It's not going to do the opposite. It will mimic the effect of this receptor, which is alpha-2. It's going to cause vasodilation. So clonidine will further cause a vasodilation. So by causing vasodilation, it will decrease blood pressure. We use this a lot in case of emergency. Okay, so these are the agents. All right, so we are done with the treatment approach of hypertension. This slide to talk about the same concept that I mentioned earlier, that the treatment should be individualized. This is the conversation that must happen between the patient and the clinician. You sit down, you talk about the risk versus the benefit, ethnicity, side effect, what is the renal status, which drug you can afford. You know, a brand versus generic, and so forth. And generally speaking, if you have a young white patient, you know, you can pick ACE, ARBS, or beta blocker, or elderly African American calcium channel diuretics. There's a concept of a sequential therapy, which is different from the guidelines. The JNC8 panel guidelines recommended that when you start a patient on a monotherapy, it doesn't matter if it's ACE, ARB, beta blocker, calcium, or whatever, we need to keep pushing the initial drug to the maximum recommended dose, and then add the second drug from a different class if the blood pressure is still not controlled. However, with the sequential therapy, their recommendation are that if the blood pressure is not managed with the first drug that you pick, you switch to the second. You stop the first one, you switch to the second drug instead of adding the second drug. You don't add, you switch. And if it still fails, you switch to the third drug, and keep evaluating every 4 weeks or so. The reason behind this switching instead of adding was that they believe that if the blood pressure is not going to be controlled with the given dosage, and if you keep increasing the dosage, you are putting your patient at higher risk for side effects, and you're not getting the benefit, you're getting the side effects. So that was the reason, and this strategy helps to find the drug, that one drug to which the patient will be most responsive, or they will be more have a therapeutic effect, and it will minimize the side effect, and it will improve the patient compliance rate. So idea is that patient doesn't have to take 3 drugs. You know, you pick the drug that will get maximum benefit. That's interesting concept, by the way. However, I understand that over time, your patient may end up taking more than just one drug. All right. Pregnancy is also a whole different topic. Women with hypertension who become pregnant or are planning to become pregnant should be transitioned to other drugs like nifedipine and so forth during pregnancy. Just remember that women with hypertension who become pregnant should not be treated with ACE inhibitors or ARBs and so forth. And surgical patient, beta blockers it should be continued. So the clients who are undergoing major surgery, who have been on beta blockers, we need to stop that. And also make sure we should discontinue ACE, ARBS for the patient who are going through surgery. And I think that's all I have for here. All right, next is combination therapy. In most patients, monotherapy may not be good enough to control the blood pressure. So especially if the systolic blood pressure is greater than 20 or diastolic blood pressure is greater than 20 above the goal blood pressure for those clients. So we add 2 drugs to achieve blood pressure of a target, especially in African American clients with hypertension. It also improves compliance because now instead of taking 2 multiple pills, they're taking just 1 medication. And you have the examples in front of you. I don't have to go over these things. Bedtime versus morning dosage. The average, as I mentioned earlier, the average nocturnal blood pressure is approximately 15% lower than the daytime blood pressure. So when you have a client whose blood pressure fail to fall by at least 10% during sleep is called non-dipping. So it is a stronger predictor of adverse cardiovascular outcomes than the daytime blood pressure. So shifting at that time, shifting at least 1 antihypertensive medication from the morning to the evening may help to control the nocturnal blood pressure dip. And nocturnal antihypertensive treatment also appears to decrease the incidence of cardiovascular disease. Very interesting phenomena. If you get a chance, take a look at it. Make sure you read about this. Now, I mentioned the word resistant hypertension earlier. So what is that? Well, it's a blood pressure that is not controlled to goal despite adherence to an appropriate regimen of at least 3 antihypertensive drug from different classes. And one of them should be a diuretic. So blood pressure that requires at least 4 medication to achieve the control is considered controlled resistant hypertension. So if blood pressure is severe, resistant, early or late onset of hypertension, or whenever you are suspecting secondary hypertension, further testing is required, and it requires a referral to appropriate specialties such as perhaps cardiology, nephrology, endocrinology, etc. So don't try to be hero. Don't try to manage this on your own. All right, $1 million question is, can we stop taking these medication if blood pressure is controlled? People are going to ask you this. Well, the answer is it depends. Some patients with stage 1 hypertension are very well controlled and often on a single medication. So after a period of years, the question may arise as to whether antihypertensive therapy can be gradually discontinued or decreased at least. So if the answer is yes, if a patient is stable, you can try, especially if the patient was on a very low dose of one drug. But after you discontinue the treatment, most of the patients remain normotensive for at least 1 to 2 years or so, and we keep an eye on them, we keep assessing them, and if you gradually taper these clients, and they do better than people who stopped taking medication all of a sudden. All right. Let's see if you were paying attention. So take a look at question number 1 over here, and you can pause and see if you know the answer. All right. Well, hopefully you picked number 1. And here's the rationale. And let's see question number 2. Go ahead and pause and see if you know the answer. And the answer is number 2. And here is the rationale. You can pause and read on your own time. And that's all I have. Thank you so much for your time. And make sure you take notes and email me if you have any questions regarding any of this. Thank you so much. Any questions?